Hello and welcome to another session of Ask WHO. My name is Nika Alexander. I'm part of the communications team here at WHO headquarters in Geneva. Today we're looking at COVID and refugees. It's actually a topic that several of you asked us to cover. And in order to do that really well, we have some special guests with us today. First, we have with us Filippo Grandi, who's the UN High Commissioner for Refugees. He's joining us here in person. He's come up the hill from his office that's just down the way. We have also Dr. Mike Ryan, who you always see here on Wednesdays. He's the head of WHO's work in emergencies. And we have with us as well my colleague Teresa Zakaria. She's a WHO health emergency officer, and a lot of her focus is on refugee health. Teresa, welcome to your very first Facebook Live with us. So we're going to start the discussion here just to get it rolling, but we really want the questions to come from you. In order to ask us a question on Twitter, you use hashtag AskWHO. It's what we use every week. If you have a question if you're watching us on YouTube, on LinkedIn, or on Facebook, just put your question in the comments, and your colleagues, my colleagues, will be sending the questions through my phone. So you'll see me heads down once in a while. Just one more item of housekeeping off the top. You'll see that we're not wearing masks. That's because we're more than a distance apart, and we're in a space that's very well ventilated. There's very good airflow. So, start off with you, Filippo. You joined us back in June for a press conference, and at that time you said that we had not seen the really very big outbreaks in refugee camps that we had been worried might happen. What's been the situation since then, or what's the situation now?
From the health point of view, I think the situation has not, from that perspective, fundamentally changed. I think that there's a variety of circumstances, some of which are difficult to understand, but some others are easier to understand. We have been able, in many high concentration of refugees and displaced, to actually prevent and respond effectively. Cox's Bazar in Bangladesh comes to mind always as a very significant place. But remember, and I think we did speak about that when I was here last, most of the refugees, displaced people, 80 million of them around the world, let's remember that, most of them live outside closed refugee setting. There's always this image that refugees are in refugee camps. Actually, refugees live in poor slums of poor cities in Africa or Latin America, lives in rural communities in many parts of the world. So there, I would say, their health situation is shared with that of the host community. So if the impact has been severe from the health point of view, they have shared that. Where I think the impact has been quite dramatic, and we see it in many parts of the world, has been more on the economic side, on the side effects, if we can call them like this, of COVID and lockdowns, because communities like those that are refugees, displaced, stateless people, they're often depending on the type of employment that is the first one to disappear in lockdowns. Very short-term jobs, precarious jobs, and the impact that we see widespread around the world on the economic side is particularly felt in these communities.
How have we'll come back to that economic side, but on the health side, you said so many people aren't in fact living in those camps, they are in difficult urban settings. How have our agencies worked together to try to help people on the health side? And we will come back to the economic side. Mike, do you want to help us understand that?
I think, Filippo said it quite correctly, is that population movement, be it refugees crossing borders or people being displaced internally or people in forced migration because of climate stress, it's creating pools of vulnerability and pools of people who don't have access to services. So existing vulnerabilities, existing weaknesses in the system are just amplified. Already, before this pandemic started, and health services in many, for example, peri-urban slums were already under pressure. Then you add in COVID, and you just light a match. And that's been, I think, the biggest struggle is getting the support needed to those frontline health services. And this is one of the things we speak about all the time, is building resilience into these systems so that community primary healthcare and the first line of healthcare is able to cope with that first wave of patients. We see this with cholera, we see this with meningitis, with malaria. It doesn't matter the infectious disease. It's a massive stress on the system. And that's where I think the agencies coming together, I mean, Teresa was part of that first Filippo, you contacted me, I think, on the telephone at some ungodly hour and said we have to come together and put something out on this issue, and we need to do it now. And Teresa led our side on that. Maybe she can speak for how we've tried to translate, because the one magic I think that's happened is we've translated the thinking about what to do into the actual doing. To a great extent, and particularly in the refugee settings where we have a little bit more control. I don't mean that in a negative way, but refugees in a camp may be in a difficult situation, but we have access to them. The difficulty is getting access to those populations who are living in vulnerable situations where we don't have direct necessarily access to them, and governments are much more responsible for including those individuals in their healthcare planning, and that's something that's even now becoming an issue when we talk about vaccination. It's coming into focus. Teresa.
So, Teresa, we chatted a little bit about this yesterday, and you were looking back to find out when that first piece of guidance went out for people, for refugees in those particular settings. Tell me a little bit about what came out of that urgent call. You said partners were calling. Mike just mentioned that as well. They were calling us to do what, and then what did we do?
I think as soon as we saw the virus spreading in many countries, many of us, and those who were working very closely with refugees, individuals and organizations, knew that the risk of an explosive outbreak in settings where people are living in overcrowded conditions with lack of access to clean water, to food, and where their livelihoods are actually very, very, very vulnerable, needs special attention. And so we came together, we tried to assemble actually those who had really operational experience on the ground to then share what could be done realistically in this type of settings. And so we came together the first time to develop a guidance, translating what we knew about the science on COVID-19 into something that can actually be implemented in difficult situations. What I was very much impressed is that hypothesis as well that came from many of those who then gathered around the table on what exactly the High Commissioner mentioned. Like, it's also a matter of livelihoods, it's protecting the survival of these individuals, where strict movement restrictions, closure of markets would actually mean loss of livelihoods, and it could actually result in like faster death than the disease itself. So it requires a lot of balancing, like that knowledge on COVID-19 that we had, the measures that we know are important to prevent the transmission of COVID-19, but also the realities in which people, vulnerable populations live in, so not to jeopardize development investments that have been done for many years.
Teresa, I'm sorry. Apparently your audio is not on. My colleagues are working on it right now. You might even see them come around and fix your mic. Apologies for the technical difficulties. We'll come back to you to get some more of that. But they were sending me messages saying that from online they can't hear you at the moment. So we'll come back to you on that.
Mika, just on that point, I think, and Teresa will come back in. It's one thing that struck me is that the plight of the refugee in the world has been something many people have felt compassion about, but few people have truly experienced in their lives. The dislocation, the uncertainty of the life of someone who's been displaced away from their home, the vulnerability that brings, the lack of access to services. In some ways, many of us around the world have been through that experience over the last year. We've all learned that we are, in some senses, refugees from COVID. Our normal lives have been taken away. Our expectations, our dreams. Our kids aren't in education. We can't go to our work. We can't get work. We lose jobs and can't find more work. So in that sense, it's a strange thing to me that I feel closer to refugees today than I've ever felt before, because I think we're all experiencing some of the traumas and the vulnerabilities that are experienced by refugees all the time. And remember, I think in the old days, Filippo, a refugee was someone who experienced that for maybe a month, 6 months, a year. And there was an expectation that would end. You would be repatriated, or you would settle in your new area, you would get asylum. It's not. People are living their whole lives as refugees. Their whole lives. So this is not something that COVID has caused, but it's something that's revealing. We're leaving literally millions of people in extreme vulnerability, and we need to have better solutions, not just for COVID, but for everything else as well. And I think that's where we need the leadership of HCR, IOM, and so many other agencies, Red Cross. We're all doing our best, but the problem is severe, and it's not just because of COVID.
It's
Basically, as you said before as well, that the pandemic shows all the cracks, all the weaknesses, whether you're a refugee and you're at the limits because of that, or if you're living in a precarious, earning your living a precarious way without being a refugee. We have a very fundamental question. Someone is asking, what is a refugee? Who is a refugee? How do you define that?
There is a definition which is the classic definition that is still very valid. A refugee is somebody who is leaving everything behind, home, work, family, his or her life, because of war, persecution, discrimination, and various forms of violence. I mean, domestic violence can be the cause of flight, just to give a sense of the wide interpretation that we give of the original definition. But of course, what is tremendously complex today is that human mobility is bigger than just refugees. People also move because of poverty, inequality. People move because of climate factors. And many of them end up having the same needs. So surely we need to remain strict in legal definition, because to legal definitions correspond legal obligations of states. So we cannot give up on that, but we need to ensure that in the response that we give to these big flows, we're broader and we address all the causes, both in terms of prevention and of response. But can I use this important question and difficult question to amplify what Mike has just said? You know, how the refugee experience relates to the pandemic experience. There's other interesting aspects and angles to that I often, and linked to what I just said about the definition. You know, because of what refugees or displaced people flee from, movement, physical movement, becomes life-saving. You need to be given asylum. Being given asylum means crossing a border and the state say, okay, you come here. You have no protection in your state. I give you protection here. This is what my work is about, ensuring this, right? From one state to the other. That movement in the pandemic has become a threat to other people. That's why governments, and understandably, have closed borders, have prevented movement. We cannot fly, we cannot travel. So, you know, this has been a tremendous challenge for us to tell governments, okay, we understand you have to protect we all need to be protected by these restrictions, but bear in mind that some people flee because of their life. And so for these people, there needs to be some special attention. You know, most states have responded positively to that, have understood that the process of seeking asylum needs to be respected. I often give the example, extraordinary example, of Uganda. Uganda, a country hosting 1.5 million refugees, not a rich country, a country with few resources, hosting 1.5 million refugees. Back at the start of the pandemic, there was a big outflow of refugees from nearby Democratic Republic of Congo, about 10,000 people. So the Ugandan government said, UNHCR, please, help. What do? We want them to come, but they were going through some pandemic peak at that point. So we had to sit down with them, help them, build isolation spaces, increase their testing capacity. You know, they stuck to that decision. They let the people in. This is 10,000 lives saved, and probably not at the cost of other lives impacted by the virus. So it's really a complicated issue when it comes to people on the move.
And we saw the same during the Ebola outbreak, Filippo. Same thing, Uganda kept its borders open, allowed refugees and people to continue to cross the border, and we assisted them with the risk reduction measures. So, and I think reminding us of the fact that the majority of refugees in the world are hosted in other developing countries, and that the vast overwhelming majority of people are hosted in countries like Uganda and others who suffer severe consequences for that, politically, economically, and they need to be supported in what they do to host refugees. Sometimes I find in Europe and other places that there's such a resistance to a couple of hundred refugees, and they have no idea that there are other countries literally hosting millions and millions of refugees. So this is one situation where South-South cooperation. And again, the idea, I think, deep in our souls, the idea, certainly in my culture, the idea of giving aid to someone seeking refuge is a fundamental principle of humanity. Regardless of what you think of that person, when someone is fleeing the possibility of death, then there is a fundamental human responsibility to give aid to support that person seeking refuge, whether it's from violence, domestic or otherwise. So it's interesting that we've seen that, and that solidarity continues, even in the face of COVID, which to me is something to celebrate. It's a tragic situation we face, but it's also something to celebrate, that generosity and solidarity is still there.
Yeah, you can, in the darkness, you can see the points of light. There have been so many things that are depressing, but there have been really encouraging things as well. I'm just going to see if Teresa's mic is working now, and we'll come back to you. In speaking of solidarity, early in the pandemic, our partners reached out to WHO and they said, you've got all this guidance for how to manage COVID in these settings, but what about these other ones, these more resource-poor settings, camp settings, which are very particular, even though most refugees are not living in camps, it's a very particular setting. Tell me about the guidance WHO developed and how you changed it, very concretely, how you changed it for a camp setting so that it's useful for the people who are managing those camps and living in those camps.
So I think what was extremely important was to bring operational people around the table to actually talk about concrete things that could be implemented. It's translating science into operational actions. So that was critical. And for refugee settings, but also for settings where there's overcrowding and a lack of access to water, sanitation, and others, it's beyond the health sectors as well. Like we needed to collaborate across sectors with beyond hospitals and beyond the doctors and nurses to make sure that the basic conditions for preventing the transmission of the virus is in place. And I think one of the good examples that we looked at, for example, is how distribution of food or of other materials could be done in a way that could help promote physical distancing, even though settings are crowded. And this is where then our operational partners contributed a lot on like what is feasible on the ground. For example, in Tanzania, I had the chance to also have a discussion with our colleagues from World Vision. They actually use local resources to make sure that there's physical separation between queue lines to make sure that, you know, people don't necessarily interact too much with each other. Now, this intervention was low cost. It promoted one of the very important prevention measures, but the feedback that was given by the refugees afterwards was actually they felt that their dignity was even more promoted, was more appreciated. And so what we're also learning from COVID-19, a lot of the prevention measures actually contribute to the prevention of many other diseases, right? When you have better access to clean water, when you have better access to hand hygiene, hand washing stations, or even, you know, better ventilation in homes, it contributes not only to preventing COVID-19, but many other diseases. So in that sense, contributing together, looking at available local resources, we were able, in the scale that we did, to also then promote better health for all, and that was quite important.
I think that goes back to a little bit to what Mike said before as well, is you don't start investing when outbreaks start or when pandemics start. You are working on refugee health from the very beginning, and in fact it's one of the host country's obligations. You talked about protection, and protection includes health protection as well. It includes providing food and health and other services. We have
just on that, I think, because it's something that, well, Filippo, I know, speaks to this all the time, because it goes the other way too. That sometimes then when refugees arrive, particularly in a concentrated setting, the host population comes under pressure, and one of your principles, Filippo, always has been, I think, is driving the idea that we also have to provide services to that population. Because you can come in and provide really good services to a refugee population, and in fact the host population itself, the people around those camps, suffer because they don't have access. So making sure we have an equity approach in delivering services beyond the camp setting and into the broader community is really important. It wasn't, the guidance that was produced was multi-agency. It was with IOM and HCR, and in fact it was Filippo who picked up the phone to me and said, we've got to move on this. We've got to move quickly. And I think that's a good thing in this response, and we've seen that. We're not there yet with a lot of things. But the one good thing, I think, in this COVID response is that we've been thinking about solidarity, we've been thinking about equity, we've been thinking about vulnerable populations from the very beginning. Sometimes that comes at the end. We do the big response and we focus in on the primary beneficiaries, and then we only think about the others, and they get left behind, and we go back and try and pick up. In this case, I think vulnerable populations were at the centre of our collective thinking from the very beginning. And the job of the High Commissioner for Refugees is to advocate for refugees. So Filippo certainly did his job in corralling us all into applying our skills early in this regard.
And together. Just to quickly remind everyone, if you have a question on Twitter, you use hashtag AskWHO. If you have a question on Facebook, on LinkedIn, or on YouTube, you can just drop it into the comment section. We have a question from Siwar, and it relates to what we were just talking about on equity. They're asking, is there a program you're working on to provide refugees with vaccines equally?
So I think, and Mike and Teresa can speak more to the more technical aspects of this. I think that in terms of vaccines, the same applies as to everything else that concerns refugees. The key word is inclusion. We need to make sure that states that have vaccination campaigns, and progressively I think all states will have to have vaccination campaigns, that refugees are included. Now, we have actually kept some statistics in that respect. Already we know for sure, explicitly 106 countries have stated publicly that they will include displaced people on their territory, including refugees, in their vaccination campaigns. That's not too bad. You know, there's about 200 states in the world. Not all of them host refugees, so we're doing quite well. We are discussing with each and every country. We're discussing with 30, 40 more countries still how to do that, and there's a number of other countries that we don't know about, but really a minority at this point. Now, the challenge is what to do, because, as Mike said, most of those countries do not have many means, do not have many resources. So, but this is where other arrangements to ensure that those countries are supported in their immunization campaigns kick in, like COVAX, for example. So what we have done from the beginning is to ensure that COVAX bears in mind in its approach, this platform, that some countries, in addition to their national population, have host refugee population. So this becomes a factor in calculating, in planning the help that the international community will give to those countries. And then there will be some extreme cases where, of course, it will be impossible, or there will be unwillingness, God forbid, but it may happen, to include refugees. This is where I think that we will have to have ad hoc specific arrangements, but I really hope that this is the last resort. You know, inclusion is key in everything that has to do with people on the move. When I was a much younger field officer working with refugees in the field, the name of the game was creating structures for refugees, camps, schools, clinics, just for them. This is not a sustainable model anymore. That's why the Global Compact on Refugees, which is somehow our big roadmap, right, that was approved by the UN a couple of years ago, has as one of its centerpieces this notion of inclusion, even pre-COVID, but inclusion also in education system, in school systems, in health system. Now, that means that for poorer countries, the international community has to give help, because they are somehow, by hosting refugees, they're performing a service to humanity. You know, the Refugee Convention says, 1951, says in its preamble, refugees are the responsibility of the international community, not just of that host country. All the more so if they include them in their national services. And this is valid also for immunizations.
Mike, can you explain why sharing vaccine is not just the right or nice or moral thing to do, but it's actually epidemiologically the effective thing to do?
I think, well, there are probably two strong reasons. One is absolutely clear right now, and that is that unless we bring all economies and all communities out of this together, some countries are going to fall further behind than they already are in terms of lives, livelihoods, and the impacts that has socially economically, and ultimately politically. And we're in a world that's, you know, destabilized by geopolitics, destabilized by climate stress. This is just one more major stressor. And in that regard, we know who is likely to be hospitalized and die. We know how the health system comes under pressure by those people arriving sick to hospital, requiring oxygen and ventilation. That's the horror of COVID-19. Unless we stop that by protecting those highly vulnerable people and those frontline workers, if we do that, we take the heat out of the pandemic. We take the pain and the suffering. That creates space for us to open our communities and our societies again. We have more choices and more options. So by ensuring that health workers everywhere and vulnerable people everywhere have access to vaccine, we're going to allow all economies to recover together. And that's going to then, and that idea of inclusion is not just a moral idea. That idea of inclusion makes really good economic and political sense. The second thing will be that as vaccines become more and more available, we could end up in a situation where 90% of the population of one country is vaccinated and 5% of another country. That virus is going to continue to transmit there. And we don't know how long the vaccination protection will last in the country with 90%. And maybe it'll spin and then it'll infect everyone in that country with 5%. And then as your vaccination coverage wanes or protection wanes, the disease will pop back and it'll start the cycle again. So putting out the fire in one place has no value unless you're putting out the fire everywhere. So I think it has epidemiologic validity, it has economic validity, it has political validity, as well as having humanitarian and principled validity, for sure. And again, just emphasizing what Filippo said, we are tracking that all the national plans have been created according to the structure and the process we've created within COVAX. All of the countries have now put their national plans on our country portal. We can see that. And regional groupings are reviewing those. And one of the parameters that we're looking at specifically is the one of inclusion. And that is one of the decision parameters in the allocation framework that says, are you including everybody in your system? And that is something that's now transparently there. Before, this was something that was not talked about. And sometimes things don't get done if they're not surfaced. And once you surface the issue and make that something that's transparently on the table, I think most countries respond to that. With regard to there is a humanitarian buffer built into the process, but as Filippo said, that is for extreme situations. And there are people that are beyond the reach of government, that live in disputed areas where it's impossible to get to. There are certain circumstances where it may fall to the international community to come and do that work. And we've had many experiences of that with polio and others, and we may need and it is great to see that that has been considered up front. And while everyone is frustrated now, today is a great day. The COVAX facility is delivering its first vaccines today. And even though it's slower than everybody wants, we have collectively developed many new vaccines in less than a year. We have tested those vaccines for safety and efficacy. We are rolling those vaccines out. And while that distribution is not something we're entirely comfortable with, at least the issue of equity was on the table from the very beginning, and we're driving for that equity. And the issue of vulnerable populations and refugees and displaced and migrants and prisoners and people living in vulnerability, that they were on the table from the beginning. In other diseases like HIV and other, people weren't even at the table. They weren't even being discussed until years after the solutions were available. We're not perfect. We will get there. But the very fact that we have successfully brought considerations about these vulnerable people right to the center of the argument and the planning, I think, to me, in itself represents progress, but not success. So the real issue is now, can we move from the progress we've made to actually successfully vaccinating these populations? I believe we can, and I believe we will. But the DG said it this morning. There's an awful lot of work left to do, and I think that's now what we've got to do, is work to get this job done.
Teresa, can you tell us, and I hope I'm not putting you on the spot, can you tell us a little bit about this humanitarian buffer, this sort of last resort kind of idea, and we want it to be a last resort. Ideally, everybody in a country is included in the plans. You don't, vaccinate certain types of your population, not others, ideally. But tell us just a little bit more about what that buffer is.
I think the biggest concern is really to have a person left behind in a country, which we don't want to happen. And so within that thinking, we felt that for safety measure, and again as a provision of last resort, that there has to be some flexibility in the allocations of vaccines, and hopefully also in the operationalization of vaccinations, to make sure that those who perhaps don't live in an area that is controlled by the government, or those who may fall between the cracks because the name or the characteristic of the group they belong to is not present in the plan. So it's just to make sure that nobody is left behind. And so we want that safety net, that last safety net, to make sure that we can include everyone. And as Mike has said, in the past for many other diseases, it has been challenging to make sure that plans, national plans, are really inclusive. When countries talk about universal health coverage, it normally pertains to their citizens. But what about those who don't necessarily have that regular status in the country? So we've moved beyond that with COVID-19, but we're thinking ahead of it as well, to make sure that there are always risks, that there will be some people left behind. And that's why the humanitarian buffer is important, to make sure that we can cover those people.
So it's basically a small percentage of the vaccines that COVAX, the facility that WHO is working on with other agencies, a small percentage of the vaccines have been set aside for use in these extreme situations.
Yeah.
Just a shout out to CEPI and Gavi have been a big part of COVAX, but we can be slightly parochial as well and say that our sister agency, UNICEF, has been a major driver of this solution. So you have WHO and UNICEF as two UN organizations who've been at the center of COVAX, but many others supporting the rollout, like HCR, IOM, are going to be involved at the country level in ensuring we get those vaccines out there. So it's a good day for multilateralism, it's a good day for international solutions.
If I can build on that, because I think this is an important point, especially for our viewers, because very often, there is a certain image of the UN being very bureaucratic, so many organizations. It's true, an alphabet soup of acronyms and all that. Now, I have worked for the UN for 33 years, and I'm very proud of that. But I have to say, this tragedy that the pandemic has been and continue to be has been paradoxically also an opportunity for us in the UN to work together more closely. Look, Teresa was talking about what we do to try to stem the spread of the virus. One key thing has been, for example, communication with communities, right? Right message about washing hands, social distancing. I mean, the communication that all of us every day listens to for the past year. Now, that communication, we, for example, as an organization dealing with large, in general, across the board with large refugee populations, we had to inject it in addition to what we communicate usually. Now, without WHO, we could not have crafted that communication, which has to be very precise, has to be very specific, because if you make a mistake in that communication, you cause a lot of damage. This is a small example, and I can give you many other examples. I agree with Mike on the vaccine management for this population. We're working with WHO. We have just signed for the first time an agreement with Gavi. We work, of course, with UNICEF, especially in the logistics. So it's a multifaceted cooperation that I think has shown, if I may say, the best side of the UN, where all of us, from our different perspectives, from our different mandates, from our different expertise and knowledge and capabilities, have been able to pull together. Again, is it perfect? No. We have a long way to go. It's not just health, it's all the other consequences, but I think that there are some important advances that we have made about working together, and not just the UN, civil society, NGOs, governments, that we will not lose going forward. We will use them for other crises because, unfortunately, our life is a life of crisis. So we have to go on and be ready for that.
there will be more. This we can answer pretty quickly. Somebody on Facebook, I think, is asking, are data about refugees included in the COVID reports that countries provide?
Yes, almost everywhere. Of course, there are places where this, data about populations on the move are not that perfect, are quite, have gaps, but again, I have to say, I was recently in Colombia, just to give you an example. Colombia, has done one of the most phenomenal things, has taken one of the most significant decisions in terms of protection of people on the move that I have seen in a long, long time. Just last week, the president announced what they call a temporary protection regime for all Venezuelans, 1.7 million hosted on their territory. And I think that there's many reasons why this was done, but one big driver has been the necessity to have reliable data on this population to include them in the vaccination campaign. And they realized that data were not so reliable because a lot of the Venezuelans were irregularly in the country. So by now, they will be regularized, they will have access to all services, including vaccinations, and the data will be more reliable because they need that. So you see, somehow, it's a bit like the argument Mike was making earlier. This is right from the humanitarian point of view, but it is also in the interest of states to manage it in this way.
Another question coming to us is, are refugee camps, have we seen them to be super spreaders or amplification points for the outbreak? Somebody might at first glance think that's been the case.
This is what we actually feared. When Mike and I spoke, I remember that faraway day, seems like ages ago, in January or February last year, at the beginning of all this, and we said, my God, in big concentration will be a recipe for disaster. But actually, because of what Mike said, because they are more controlled environments, it was actually paradoxically easier to prevent the spread there than in other places. Now, I want to make one thing clear. This is not to say that the camp approach is the best, because it is very exclusive. It is very confining. And states are gradually all understanding that have the refugees more in the community and included in a community with proper support given to that community is the best approach. But for the emergency response, I think it was easier in a controlled situation, and therefore I would say that neither camps nor, perhaps more important, refugees on the move have been super spreaders, not at all.
No, and I think and not because it couldn't have happened. In other words, I think a tremendous amount was done in readiness. And, we talk about long-term preparedness, and we talk about those moments you get, those days or weeks you sometimes get of advance notice that something bad is going to happen. And how you use those days and weeks is very important. And I think two things happened at the camp level. One was because of the situation in the camps and the likely catastrophic effects of letting disease in. A lot of work was done on triage and screening and controlling access to the camps in a way so that there was less chance that someone would come in with the disease, and then having really good surveillance to pick up when there were cases, having pre-isolation centers, having in the camp communities, having areas where someone who had a cough and a fever could be temporarily isolated until they had care. And providing a good standard of clinical care when there were cases with oxygen and other therapies. So I think a lot was done to avert the camps becoming zones of amplification. So sometimes it's very tough in epidemic response, it's very tough in epidemiology. When the fire doesn't start, then no one remembers the fire prevention. They all say it didn't happen. You invested so much money and resources and nothing happened. And I usually say, good. When you get I often use the analogy of getting your car serviced. When you get your car serviced every year and you get your insurance on your car and you get to the end of the year, you don't send a bill to the insurance company asking for the money back. You bought insurance in case something went wrong. It's still a good investment. And I think that's the essence of readiness, is being prepared to do things to avoid a reality. And when that reality is avoided, you should celebrate. It is not a waste of resources. And it's the same in health in general. It's the same in managing and including refugees. When we include refugees in our lives in communities, and we give people dignity and respect and the chance to have a livelihood, then that has a stabilizing effect everywhere. And it prevents secondary displacements and tertiary displacements, and it takes a lot of the tension out of the situation. And I think that's what we have to be doing. What we're always trying to do in our lives is get stability, predictability, be able to send my kids to school, be able to have a livelihood, have access to healthcare. What forces people very often to flee is not always conflict. In fact, many people live in conflict situations. What often forces people to flee a situation is when they lose hope for the future, when the school closes, when the hospital closes. And then people look at the landscape of their lives and they see the conflict all around them, and they see the things that they most cherish: education for my kids, healthcare for my father or mother. That disappears. To me, very often, in my experience in talking to people who flee, that's as much part of the equation of movement as anything else. It's that loss of hope in the place I am. Who wants to leave their home? Who wants to leave the place they were born? Who wants to leave their farm or their community? Nobody wants to move. Nobody's choosing to do this. And I think if we're to truly address these issues, we have got to recognize that investing in including people in this and reducing their risks and making them stable within our communities and give people dignity. And in doing that because I think you were careful, Filippo, to say that the camp situation isn't the ideal way to deal with this. But in the situation we were in, there are that many people in camps, it was necessary to take the preventive actions that were taken. And it's to the credit of those agencies that care for people in camp situations, and it's HCR, it's IOM, it's Red Cross, and there's so many other agencies and national government agencies, that this crisis was averted, that this tragedy was averted.
Maybe just 1 second to add. This last point is important. It's national government agencies. Mm-hmm. You know, it's where governments saw that early mm-hmm. and prepared that this became. I mean, the Bangladesh government was really exemplary in what they did to try and prevent the spread in Cox's Bazar, which is, 1 million people in a small area, no social distancing, poor hygienic facility. Now, we proved a lot, but because they gave us the space to do it and they led it. The Jordanian government, first one to not only include, but to publicly make a show that the refugees are included in their first vaccinations. Mm-hmm. These are really visionary acts, not only humanitarian, but also strategically very important.
Exactly.
Teresa, I'm going to come to you. We have a question from Laura Bahina. And she's asking how are community health workers used she's asking about the camp setting, but it could be in wherever refugees live as well. And I know we often we think about it's outsiders coming in, but in fact it's local government, local people, and local health workers who are the first and the last on site as well. So this question is specifically about community health workers.
I think the good examples and the good practices that we've seen, for the fight against COVID-19, but also many other diseases, are really those that are driven by communities where they get together and distribute responsibilities. They believe that yes, there is a risk, that yes, they are empowered to actually take actions and actually then do that. And we are seeing community health workers in many locations even going home to home just to make sure that people understand that there is a risk of COVID-19, and even to look at, do you have any members of your family that is at risk of severe disease, for example, and make sure that these are the first one to be given the extra protection equipment, for example. That neighbors come together as well, mediated by community health workers, to see then how living arrangements could be improved by maybe merging a couple of families together and making sure that there's more space for those who would be more vulnerable for severe disease. These aren't things that we can think of from here, from Geneva, or even from at the national level. These are the things that community-based solutions that are found by communities themselves and implemented by themselves. So we're seeing a lot of these examples in many countries in Southeast Asia, but also in Sub-Saharan Africa, Rwanda, and Kenya, who are really looking at this. They've even established mechanisms to make sure that those who have poor living conditions would be the first one allocated with alternative accommodation facilities, including referrals to like community repurposed structures should someone become ill.
Just on that, community health workers, I think we also just need to reflect that 80, 90, in some cases 95% community health workers are women. And yet our health services are dominated at the top by men. So it's not just about empowering community health workers, it's about recognizing who delivers those services and the courage that those mainly women show. And it's also, I think we also risk, and Teresa used a very important word, empowerment, and then she said investment, talked about resilience. Communities are not there to be the beneficiaries of our generosity from governments or from HCR or WHO. Communities to me are the first, second and third line of defence, the best line of defence. And that one thing I think that has defeated us more than anything else in this pandemic has been the victory of individualism over that sense of community, that sense of community ownership, that sense of me as a member of a community with responsibilities to me, to my family, to my community, and how I support my community and do what I do on behalf of my community. Sometimes we see our goals as too far away, national goals or my personal goal. But for stopping, when you look at what stops COVID is my behavior. Me reducing my risk, or my risk that I represent to my parent or to my neighbour, and what can I do to assist my neighbour? It starts, in epidemiology, we often talk about the N number, the population, N equals 1 million or 1 billion. In epidemic response, in reality, N equals 1. One life matters. One person matters. The action of one individual matters. And the ones add up to the thousands, and the thousands add up to the millions. And sometimes we think we have these grand concepts, and we talk in billions and millions, and we talk in models, and we dehumanize the response. Because in the end of the day, epidemics spread, and this epidemic has primarily spread by action or inaction on the part of individuals, or the lack of knowledge, or the lack of resources, or the lack of empowerment for individuals to take the action they need to take. Empowering communities with knowledge, with resources, and with, I think you said it, Teresa, the right to make their decisions, the ability for them to take action and empower themselves. And I know that's a very dangerous concept for some governments, but I think that idea that communities be empowered is not a threat to the great order of things. It's actually a way of turning this and many other areas of social justice around.
That was a question from Laura Bahina, the one on community health workers, and she says, thank you for taking my question. Yes, community empowerment, ! We're glad you're in favor of community empowerment as well. This is a question from Dalia Hakala. She says, talking about Colombia, there's a large population of Venezuelans in other countries in South America as well. Peru, Ecuador, among others. Can anything be done in regards to those who don't have that, those people who are displaced but don't have that more official refugee status?
By all means, we are working with all states in the region that host Venezuelans to try and move towards the Colombian solution that now we have, meaning a regularized status. And this is true for Ecuador, Peru, Chile, Brazil. Now, each one of these countries has been very generous in hosting hundreds of thousands of Venezuelans. We estimate that well over 5 million have left the country in recent years, and most of them have stayed in the region. So the impact has been very, very much felt in all countries. Colombia is the one receiving the most because it is the closest. So it was more urgent there to have this regularization program. But we're working also in other countries as well. Now, some of them have actually already developed some arrangements, Brazil, for example, but actually all of them, Peru, Ecuador, all of them. We really, our appeal to all these countries, and I think this is what Dalia is referring to, is regularize as much as possible. And now, in addition to all the other reasons why regularizing is important, we have the pandemic, which makes it even more necessary in order to have an orderly inclusion of the... None of this country will exclude, let me be very clear, Venezuelans from vaccinations, like they haven't excluded them from healthcare, from education, from access to the labor market. But regularizing makes it more manageable for the government and easier. It's easier to track down individuals. It's not a matter of control, it's a matter of good management, which, by the way, it has also some positive effect from a security point of view. So, it is a win-win situation to regularize. I fully appreciate, we should not be naive. The presence of refugees, migrants, foreigners on the move, people that are not nationals, is always politically sensitive. Always, especially in situations like the pandemic, which have generated a lot of new poverty, marginalization. So for governments who are already struggling to serve their own population to say, but in addition to that, we have 500,000, because we're talking about these figures. It's not these 200 that arrive in Europe and that make governments fall and rise. And, this is serious population movements that we're talking about in Africa, in Latin America. So I think that it is also very important. I often go and see leaders, ministers, governments in Europe, in rich countries, right? In the north of the world, in the northern hemisphere. And, I always hear this, we understand solidarity, but we have to be careful politically. What about leaders that, in poor countries, that have to make decisions about 500, about 1.7 million, like the other day, President Duque in Colombia? So I think that we need to have due consideration for the incredibly difficult decision that that incredibly difficult situations which these decisions generate. This is why international solidarity around this is so important, because governments can say to their population, we have made this decision because it's the right thing to do, but also we enjoy international assistance to implement this decision. And otherwise, without that international decision, first of all, many governments will not have the courage to make inclusive decisions. And second, if they do, they risk being very destabilizing politically, and this is to the detriment of everybody. So that's a very important aspect. This question points to a very, very important issue.
Mike, we have a somewhat technical question here, and then we'll wrap up. Sergio Coscolin on Facebook is asking, how can refugee centers ensure proper ventilation? So it's very specific. WHO has talked a lot about how COVID spreads in a range of ways, from big droplets, small droplets, ones that hang in the air, fall on surfaces, and so on. So this one's in particular about ventilation, and maybe Teresa can come in as well.
It's a challenge. Adequate ventilation is something we all need, and it's not just an issue about COVID. I mean, we've seen indoor air pollution and cooking indoors and the long-term health effects that can have. So adequate ventilation is as important as clean air and clean water. All the more so in the era of COVID, where the risk of being infected with COVID in a social situation is driven by three things: the proximity you have to other people, the duration of time you spend there, and the intensity of the activity you partake in when you're there. If that happens at close proximity with many people, and you're carrying out intense activity, and the area is poorly ventilated, then you've created a perfect storm. You've created the opportunity for super spreading in that situation, because a disease that should only spread very, very close by to someone may spread much further in that situation. And therefore you can get more long-range transmission, and you need ventilation to be able to exchange the air, change the air. That's what ventilation means. To ventilate something is to allow new air in and the old air out, and in doing that you disperse any viruses that are hanging about. That is very hard to achieve in a refugee camp-like situation, or in a multi-family home, in a favela, or in a peri-urban slum. So the context is everything. It's not the context of the camp; it's the context of the crowding that drives that. Now, what we have done and maybe Teresa will speak to this, we've worked very closely with a network that we've created called Techne, which is a network that particularly for healthcare facilities, for triage facilities, for feeding facilities, where we've tried to redesign facilities so they maximize ventilation, they maximize the design and the spacing, which allows, with low-tech approaches, to create more natural ventilation, to create more space, to create a flow of people through the system where there isn't as much crowding or remixing of individuals. And we've done that for healthcare facilities, for triage facilities, and we've done that at the lower tech end for camp-like settings. And that's proved, I think, quite effective, Teresa, in risk management. The difficulty arises, camps by their nature have a finite space, and that space is very precious. And families live together very often in a tented environment. It is exceptionally difficult, as it is in your own home. And when we look at the secondary transmission of COVID, right now, COVID's most successful transmission opportunity is actually in homes. Secondary transmission occurs in homes very frequently because people are there for a long time, they're mixing, there's a long duration, and they're doing all their normal activities. You take that same activity that might occur in a house of 100 square meters and you pack that into 10 square meters in a tent, then all of the risks increase. So it is very difficult to manage that risk. So the primary objective is to stop the disease getting into camps, to have really good surveillance and contact tracing. So if a disease arrives, you can quickly isolate a case and quarantine the individuals who may be contacts. So you stop the fire starting. And then to have those risk mitigation measures in place. Teresa may speak more about how we try to mitigate the risk in the general population in camps, but we have done a lot to try and at least manage the ventilation issue to the best degree we can as part of a more comprehensive solution. Because controlling infection is about many things, including ventilation.
Yes, and I think you point that exactly right at the center of the problem. It's multiple layers of problems, and especially in settings where everything is difficult. People are living in overcrowded houses with no windows, perhaps, with multiple individuals inside the household. We need to approach it at multiple levels at once, like in the household itself, what can be improved within the available situations. And our approach would then be to really identify the most vulnerable to severe diseases within the household and make sure that the best available ventilation into that house is provided to this individual. A lot of partners as well working in humanitarian settings have really tried to also improve the environments, right? From hygiene to additional ventilations to the people living in these type of settings. And I think one of the good practice as well of collaboration among UNHCR, IOM, and WHO is also to make sure that any isolation facilities for COVID-19 cases are really designed in a way that would ensure that these safety measures, including proper ventilation, is ensured. And as Mike said, like, the more we can identify cases early and make sure that they are treated in a safe facility that would prevent them from spreading the virus further, the more we're also protecting the rest of the population. So it's multifactorial. Things need to be addressed in through different approaches at once. But I think one thing that we have definitely learned is that there are always local solutions that can be used, even if it's to improve the situation minimally. But for this to happen, then we really need then the individuals themselves to identify the solutions and implement these solutions. So again, community-driven.
Thank you. I'm going to, Filippo, I'm going to read the names of the countries where people are watching us from. I would venture that every one of these countries is hosting refugees in one way or another, and then I will, it's a long list, which gives you time to think, and then I'd like to come back to you. What's the one thing you want people to remember, to think of when they think of refugees? So I'll come to you in a little while. So we've had on LinkedIn people listening, following us from England, India, the US, Pakistan, Brazil, Romania, Mexico, Iran, Austria, Uganda, Morocco, Sri Lanka, France, Algeria, Colombia, Ecuador, Lebanon, Saudi Arabia, the Netherlands, Rwanda, Panama, Uruguay, Turkey, Ghana, Canada, St. Vincent and the Grenadines, Niger, Greece, Denmark, Mauritius, Portugal, Cyprus, Jordan, Italy, Germany. We do this every time. A few more countries to mention: Zambia, Cambodia, the Philippines, Angola, Germany, the UK, Bangladesh, India, Sri Lanka, the US, Thailand, Vietnam, and Myanmar. Thank you so much for watching. Filippo.
Perhaps one message, not perhaps, for sure, one message that I'd like to really leave behind. I think this conversation, including its very practical details, local solutions, as Teresa said, so important. I think if there is a message that I think it conveys is that giving refuge, let me use that word, giving refuge, protection, safety to people that are fleeing from all sorts of horrible things is possible even in times of COVID, in times of pandemic. I think it's important because I fully appreciate that there is an apprehension there. You know, we have gone into such a strange way of life in the last few months. Can we do this extra effort? Can we continue to host, receive, give protection to people on the move? It is possible. It is possible. It is complex, but it is possible if there is will. And that will, of course, is governments, but that will is also the will of each one of us. That's what solidarity is. You know, solidarity is a positive feeling towards those that are more disadvantaged than we are. And refugees, displaced people, very vulnerable migrants, prisoners, other people that are in particular vulnerability need a special solidarity. The worst thing that can happen, and there is a risk of that, is that the pandemic increases the risk of stigma for these people, that they are perceived, they become a scapegoat, they're the ones carrying the virus, they're the ones spreading, they're the ones taking away the scarce resources that governments make available when we become more poor and more exposed. No, I think that it's the contrary. We have to embrace solidarity, but we have to mobilize the resources to support that solidarity. We cannot take it for granted. So mine is appeal of, an appeal for special solidarity in these very special times.
Mike, anything to add?
No, I can't beat that.
Right?
No.
Teresa?
I think a lesson as well that we took from last year, working specifically focusing on populations who are living in a disadvantaged situation, is that they are vulnerable because of their living conditions. But this is not only related to COVID-19. Like the improvement that we're trying to do by increasing a population's capacity to prevent COVID-19 will also serve in the long term to prevent many other diseases, and that is extremely important. We're actually talking about, the sustained development goals and everything that we want to achieve. So making people live better is going to take us to the end of this pandemic, but also to prevent other pandemic to happen in the future.
Thank you. I like that we're able to find the message of hope, and hope for not just for the present, but for the future as well. Thank you so much for joining us, the UN High Commissioner for Refugees, Mike, as always, our Head of Emergencies, and Teresa, Zakaria, an Emergency Officer in the Emergencies Program at WHO. I'm Nika Alexander, part of the Communications team here at WHO. Thank you for joining this Ask WHO Live Q&A. We're here every Wednesday. We do other sorts of events as well. There's press conferences, so do tune back into us and to UNHCR as well. Thank you for being with us.